The other thing that I'm really passionate about because of the potential patient need is knee embolization.
Yeah, so knee embolization is an ultra exciting procedure. And I think we have the ability, like you said, because of the population who's really suffering from knee pain, to make a huge impact. And I break down the knee patients really in two cohorts. So the first cohort is the patients who are post-surgical, so the patients who've had a previous knee replacement. And what's interesting about this is in that post-surgical patient, there are really two cohorts of patients. There's one, the patients who've had spontaneous bleeding. And albeit it's rare, because of the amount of knee replacements that occur on an annual basis, it's not rare to see patients who have on and off joint effusions that really are made of blood. And it's called hemarthrosis, as you know. And so genicular embolization or knee embolization in that setting works exceptionally well.
That's well established,
yes.
Old data.
Old data, perfect. And in the setting of osteoarthritis, what's most impactful, what we see, is that the patients who have synovitis and associated osteoarthritis. So by synovitis, as you know, we mean inflammation of the knee joint, but the patients who have a palpable, reproducible pain. So they can describe to you and say, my knee hurts here, or most often hurts here. When we press on the knee, they can reproduce the pain, or we can reproduce the pain when we're examining them. Those patients do remarkably well. I would say all but the patients who are the most advanced, and I would say really far advanced patients, almost everybody else could really substantially benefit from a genicular embolization. So as you know, when we break them down by grading scales, it's really that grade 4 patient, and it's who doesn't benefit as much. But interestingly, that grade 4 patient can still benefit. It's just a shorter term benefit than those patients who are earlier on. So the population that can really be affected in a great, meaningful way is really the majority of osteoarthritis patients.
Wow, and that's a lot of people.
It's a lot of people.
I mean, it's basically you've got to be troubled by it most days, right?
Yes.
And, probably taking anti-inflammatories on and off
Absolutely.
at least. We know what else is available. People are getting joint injections, which last a few months.
Yep.
But what you're trying to achieve with this embolization is a robust, kind of longer-term reduction in inflammation in the knee, right?
Yes.
And what's your experience? I mean, I've seen the papers, but what in your patient cohort, how long do you think the average person gets a pain relief benefit for?
Yeah, it's a great question. So we as you know, we typically use a 50% failure rate or recurrence rate as the turnover for when patients recur, as to say, what's your average time?
Right.
What's great is we don't really know that yet because we haven't gotten that far.
Okay.
We've been, as you know, studying this for over 8 years now, but suffice it to say, what we know is at a 2-year and a 3-year point after having the procedure, roughly 75 to 80% of patients who had pain relief still have pain relief. And so that's substantial.
Yeah,
and so if you tell patients in real numbers, if you did well after the procedure, you have a 70 to 80% likelihood of still doing well in 2 years.
Yeah.
It's definitely going to be much more substantial than, as you just mentioned, with injections, where PRP and steroid injections and other things, they can work, but they usually work in the short term.
Yeah. And just to clarify for people, this is not patients who should be getting a knee replacement, right?
Yes.
Because they're the ones with severe disease. So this is the patient stuck for 15 years with a painful knee, but they're not bad enough for the surgeon to yet replace.
Exactly. So this doesn't really serve exactly as a replacement to knee replacement.
Yeah.
If they are already on the path to get a knee replacement and they need it now, for example, they should probably get a knee replacement because it's a structural issue, and they may be so far advanced that that's going to be their ideal therapy. But the patients who have not yet made it to that point and are really being maintained, like you mentioned earlier, with either anti-inflammatories, being bothered by their pain on most days, and perhaps get relief from an injection, but it's not durable, those are ideal patients.
And my understanding is, so you're doing this, I mean, I've done them for bleeding mostly, but you're doing this as a maybe a half-day procedure.
Yes.
Like if a patient comes into your clinic and they're going to get an embolization, what happens to them in layman's terms?
Yeah, so in layman's terms, we go into a blood vessel with a needle. There's no open incisions.
And that's the groin or the ankle?
Exactly. So we can have two choices. There are benefits to either, but suffice it to say, needle, and then we put a small catheter, and the catheter is about 0.6 millimeters in size, so very small. It's a uncooked piece of pasta, if you will, I'd say, in thickness. And we track that into the blood vessels that supply the area of inflammation in the knee. We inject these microscopic spheres, and those spheres, if you can imagine, are like microscopic particles of sand, and they basically slow the blood flow down to the areas where there's inflammation. Those areas of inflammation have too much blood flow, and that's what we're doing. We take out the catheters that we put in. After we're done, we keep the patient for a couple hours to recover, and they walk on out after this half-day procedure. And what's remarkable is, with no open surgery, you can achieve an amazing pain result. And, in this type of procedure or in this setting, patients can go back to work the next day and they can have regular function. So it's not also going to change their whole life, where I think part of choosing any therapy for a patient often involves choosing how much is this going to impact my day-to-day life? Am I going to have to take off 4 weeks? Am I going to have to have someone help take care of me, my kids, et cetera? This is really, fits in very well with somebody who's got a busy lifestyle or somebody who's retired. I think it can work either way.
Yeah, and you're doing this with just some local anesthetic and twilight sedation?
Absolutely.